So thank you everyone for joining us for our webinar tonight. The title of the webinar is Indigenous Peoples of Canada's Mental Health, and we're focusing on Indigenous Cultural Competence with a mental health perspective. And so here with me today I have two speakers, Rose and Kiera, who are going to lead us through this webinar. And if you have any questions throughout the webinar, just feel free to put them in the comments section of Zoom or of the Facebook Live link, and we'll address them at the end of the webinar. So I will turn it over to our excellent guest speakers and have them introduce themselves.
Sure. Let me introduce myself, and then I'll turn it over to Kiera for your introduction. My name is Rose LeMay. I come from Taku River Tlingit First Nation, which is in northern British Columbia. It's a fairly small community, similar size to a lot of First Nations communities across Canada. There's about 300 of us in the world. I am also the CEO of the Indigenous Reconciliation Group, and our mandate of our company is to provide cultural competence adult education. We started in health, now we provide to a lot of other sectors across Canada. I used to be working for Health Canada. I was a senior policy for First Nations Inuit Health. I have also worked internationally in Indigenous mental health. But I think what was really important for this group is for me to share that I am so proud that my son is a pharmacist. Kiera, would you like to take a moment to introduce yourself as well?
Ante, Kierra kamio kisagaw na si Bason, kaya te nagawadsig otunia. Hi everyone, my name is Kierra FineDay. I'm from Sweetgrass First Nation, located in Treaty 6 territory in Saskatchewan. I am a Nehiyaw Isweo, which is a Cree woman, and I am currently a full-time community pharmacist here in Saskatchewan.
Thanks, Kiera. I am looking at the key terms slide, and I just want to cover a couple of them before we get into the content of cultural competence. We're going to talk a little bit around cultural competence. We're also going to talk about mental health within Indigenous people's well-being. And I should say up front, this is a fairly short webinar. We're only going to be touching on some points and at a fairly high level. There are a couple of key terms I do need to cover, and it really is around the word Indigenous. In this time and place of reconciliation in Canada, words really matter. And I know that there's a whole bunch of words that may have been used in the past to describe Indigenous peoples, and I would at this point like to encourage all healthcare providers to use one of three terms: First Nations or Inuit or Métis when serving First Nations or Inuit or Métis clients. It's quite important. There are some variations across the country. What some First Nations may also use other terms, but they're a local variation. And so across the country, nationally, the three safe terms to use are First Nations, Inuit, or Métis. I'm not going to cover the terms that are on the following terms on the slide or the next slide. I encourage you to read that in your own time, if only to say these are the terms which I will continue to use through this presentation as we talk first around cultural competence. Cultural competence, a skill that we have in order to build relationship with people of other cultures. Really important in healthcare, cultural competence, because without cultural competence, our patients don't necessarily receive, or patients or clients don't receive the best care that they deserve in the way that they want it. But to talk about cultural competence, we first actually have to break down this construct. What is culture? I use the analogy of the iceberg that you see on the screen. A culture is a bit like an iceberg. You can see the top of an iceberg from miles away, but it actually takes some time when you get up close to it to see things that are just below the surface of it, and you need to spend a lot of time in a culture to understand that big piece that is way down deep in the water. Culture is actually quite complicated. There's some things that we see easily. There's some things that we might see if we spend a lot of time. But the real driving aspects of values and beliefs, they're way down deep on the culture iceberg, if I can use this analogy. Another way to put this, culture, the teachings, values, and beliefs that you were taught by your family, by your community, and your culture of belonging. It is also a lens through which we see the world and we interpret all others. And it's a gift. Sometimes in healthcare I hear the phrase cultural neutrality. If we can simply be objective as healthcare providers, can I poke a hole in that theory? There's actually no such thing as cultural neutrality. We can't take off our culture. It comes with you. When you go into the pharmacy, it comes with you. When you go to meetings, it comes with you every single time that you serve your clients. And so the secret of cultural competence then is building your own awareness of your culture so that you're aware of how it supports your professional service or how it might have unintended impact on it. Culture influences so much of how we interact with others, everything to what we quote call professionalism, to communication. What is good communication? What is bad communication? That's culturally driven. What's the appropriate way to ask questions? What is the inappropriate way to ask questions? Also driven by culture. And simply put, we are like fish in water. If culture was the water, sometimes we don't notice how pervasive it is until we travel internationally and we're with people who are not from our culture, and then we start to realize all the things that we take for granted as part of our culture. And so then I say every client who comes in your door also brings their culture. And so their values and beliefs, their definitions of what good service is, their definitions of what good communication is. And you may not know what culture they bring in the door. And so it becomes even more important for you to build your own self-awareness, to know your own culture, in order to use your culture as a way of building relationship with others. Now, there are so many ways that culture influences everything we do. It covers what is humor. Have you ever been in a crowd and everybody's laughing but you? Perhaps that's a cultural joke that you are not part of that culture. Or even worse, are you the only one laughing? Probably about culture. It covers so much around nonverbal communication. Does a head nod mean yes? Does a head nod mean no? Does when an individual scrunches up their face, does that mean they don't understand? Does that mean they're saying no? Those are all very culturally driven. And by the way, you have clients that come through your door that probably show all of those nonverbal cues, and they're all so different. I ask this because I ask you to wonder about and to think about and to find out what are the cultural cues of your clients of First Nations, Inuit, and Métis communities around you. Do you know what First Nations, Inuit, and Métis cultural cues are for discomfort, how they show pain, how they don't show pain, how they ask questions, how they may not ask questions? Those are all culturally driven. The other piece I want to pick up on in this whole slide, because this is really a lot of different examples of what culture influences, and it's not about what is right or what is wrong. That's not at all about it. But culture influences so much of our interaction. The one I wanted to pick up was the pause theory. There's a lot of evidence around this. I want to say, let's think about the pause in any kind of team meeting or communication. The pause references that space and time when one person stops speaking and the next person starts speaking. And it turns out this pause is culturally driven. For those of us who went to university, who spent a lot of time in mainstream culture in southern Canada, we're probably quite used to about a 2-second pause theory. And when that pause is longer than 2 seconds, people tend to get awkward. They pick up their phones, they pick up the pen, they say it again. So here's a point that I want you to consider. First Nations, Inuit, and Métis cultures may have a much longer, culturally appropriate pause theory, all the way up to 2 minutes. And so while we're wondering, did they hear us? First Nations, Inuit, and Métis clients may be taking what is a culturally appropriate amount of time to think about what you're asked or what you said, to figure out how to say it in a good way. Think about the words that they want to use so you hear them, and that might take a while. In that pause, instead, we might be asking, wow, did they hear us? Should I say it again? Should I repeat myself? Should I say it louder? Should I say it softer? Do I assume they didn't hear me? Do I assume they don't understand? And that's what happens when we project our own culture on others. Pause theory. Whole bunch of examples on the slide. Kiera, I'm wondering if there's anything you want to add from your real world experience in pharmacy.
One thing that I would mention, just as I guess a real world experience that I had in one of my final preceptorships as a pharmacy student, was I had the opportunity to do medication reconciliation with an Indigenous elder in the hospital. And when I was asking them about their medications and if they understood what they were for, etc., they were talking to me, but then they began to tell me a story. And so I let them tell me the story because as an Indigenous person, I grew up with the value that when an elder is speaking, you listen because they're teaching us. So it was I guess a more lengthy story, but I did listen the entire time. And at the end of the story and the med reconciliation was all finished up, my preceptor actually pulled me aside and said, Kiera, you need to take control of conversations when you have interactions with clients like this, because you only have so much time in a day. And I just made sure to explain that as an Indigenous person in my culture and where I grew up in my community, we're not supposed to interrupt elders when they're teaching us, because when they tell us these stories, there's a lesson in them. And I guess that's just an example of how culture influences us, and I guess the difference between individuals in that aspect.
Thank you for sharing that, Kiera. I think it's a great example of the cultural expectations that are potentially different across different cultures. I was thinking about some of the work that we do is up north in Nunavut, and we talk a lot around learning styles, which is also culturally influenced. And in terms of Inuit culture, in learning, there's an expectation that one doesn't ask questions of those who are teaching you. And so then I often wonder, do our Inuit clients who come into pharmacies, are they following their culture, don't ask questions? And maybe they really do need more information, but their culture might say that, like, have a different way of interacting. So these are all things to consider in achieving service excellence to First Nations, Inuit, and Métis clients. Can I move on to cultural competence in the pharmacy? And I think this is just simply a summary of the things we've talked about thus far. Is that you as a pharmacist bring in your culture every day to work, and so do all of your staff. And so we define cultural competence then as your self-awareness of your culture. Do you have a short pause theory? Does that mean sometimes your clients don't have time to answer? Do you expect people to ask questions when they don't understand, when perhaps that is not their culture? There's no right, there's no wrong, there is no judgment in this. But we ask that you think about your own culture, because the more self-aware you are of your own culture, the more able you are to reduce its unintended impacts on your patients. It also may open up the space between cultures for you to learn from First Nations, Inuit, and Métis cultures, and First Nations, Inuit, and Métis clients. In essence, every patient who walks in, or every client who walks in your door, is bringing in their culture too. And it is a gift, and it's a learning opportunity. Kiera, was there anything you wanted to add at this point?
Yeah, I guess in relation to cultural competency in the pharmacy, So for myself as a pharmacist, and I'm sure you all do as well who are listening, you try to make your clients feel welcome, no matter who they are. But one important thing I would say is to be mindful when it comes to Indigenous clients that it's important to remember the history of this country and how that history might impact the Indigenous communities and the way we put our trust into the healthcare system. So just knowing how to knowing the language, like the difference between asking for someone's treaty card when maybe you should be asking for their status card, because one is a correct term and one isn't so correct. It's just things like that that I think help people feel more welcome when they come into the pharmacy or even just in the healthcare system in general, because I mean for anyone it can be um, I guess a bit intimidating at times, or maybe they're not the most comfortable or hesitant to kind of ask questions. So I think that's just something to keep in the back of your mind at work in your practice.
That's great. Thank you, Kiera. It occurs to me that I should mention that we're covering all sorts of material really quickly. And I'm hoping that some of you may be having questions and you know where to make the notes from them, and hoping that we can have a little bit of discussion at the end. There is an additional layer of complexity around cultural competence for serving Indigenous clients. And I do want to talk really briefly about some of it. It's not the most comfortable topic, but I think it's important as pharmacists, as healthcare providers, to be aware of historical impacts, because sometimes your Indigenous clients will walk into your pharmacy with a level of fear, and it's not actually about you. It is simply that in their past experiences of healthcare, it has not been in their best interest. And so I want to talk about a few of them if to pique your interest to learn more. And one of them is actually the Indian Act and the status card, which Kiera had mentioned. The Indian Act, it's an old law, 1876, a whole bunch of revisions on it. But let me tell you the basis of this Indian Act, because this is upon the Indian Act is based the whole healthcare system, which is separate for First Nations and separate for Inuit and so some jurisdictional complexities. The Indian Act was set up because the federal government believed that First Nations, or the word of the day, Indians, which by the way, this is not a safe term at all, and I only use this term in relation to the Indian Act itself. Back in the day when Canada got its start, they also put into place this Indian Act, and it was based on the belief, and I quote from when they were debating this thing, that Indians will never achieve the intellect of adults, therefore they shall be treated in their fiduciary duty, meaning that the federal government gave itself legal decision-making over First Nations almost only 8 years into Canada as a country. And that is fully based in an absolute racism. There is no way to call this anything but racist. That Indian Act has had so much impact on the relationship and lack of relationship between settler Canadians and First Nations, Inuit, and Métis. Some of you may have been looking at the picture, and it's true. In the Indian Act, there used to be a definition, an interpretation or definition. You see it highlighted at the bottom of the slide. The Indian Act actually had a clause that said the expression person means anybody but an Indian. This thing was always set up to take away rights, not to include us. From this Indian Act is based residential schools. From this Indian Act is based the lack of legal rights, such as we only got the vote in 1960 to be precise. And from this Indian Act is also based things that we see today. The separation of healthcare from the Canadian Health Act for most Canadians, and then NIHB for First Nations. It's based way back in this old history, which is based in a completely racist perspective of the world. I want to just quickly highlight a couple of different aspects that are specific to healthcare. There was, of course, a time in the Indian Act of which they set up a reserve system. I'm not sure if any of you have heard about this before, but the reserve system used to be a bit of a jail, really. First Nations who were restricted to their reserves, and now we refer to them sometimes as First Nations communities or First Nations reserves. There was a time from about 1910 all the way through 1960 that First Nations were not even allowed to leave their reserve without a pass. And there's an example of a pass that Edward from Beardy's was allowed to be off his reserve for 2 weeks back in 1932. I put this up there because the person who would have been able to write this pass was an agent of the federal government. And now it's a fairly significant slur and offense. The word used to be, quote, Indian agent. So bear with me as I kind of continue my story a little bit, and then as I roll it back into the impact on healthcare today. On the right is what is referred to as an e-disc. First Nations, Inuit, and Métis were all impacted differently through history. First Nations are very much impacted by the Indian Act. Inuit were very much impacted by things like sled dog slaughters and by all sorts of other aspects of life. But here's one thing that I want to highlight for you. On the right is an e-disc. When the federal government was forced to serve healthcare needs of Inuit in the 1950s, which is in and of itself a long story, they put in place these e-discs. And an Inuit person or an Inuk would actually have to carry one of these things in order to receive healthcare services. The federal government didn't even show respect to the Inuktitut language. They never used it, and instead they put these numbers in place. The reason why I want to show these is because First Nations, Inuit, and Métis will remember a time when the Indian agent had this much power. And the truth is that the Indian agent was also the healthcare agent. And so First Nations, Inuit, and Métis may remember times when somebody in a white coat, somebody who showed a level of power over them in the healthcare system, did things that were not in their best interest. And so then I come back to, you may have Indigenous clients who come into your pharmacy who carry a level of distrust. And I ask you not to take it personally, but I ask you to think about then, how do you build relationship? When First Nations and Inuit Métis may have experienced fairly negative experiences in the healthcare system in the past. So that's the one complexity, colonization, the lack of inclusion. The next complexity, as many of you can probably know and deal with every day, is just the straight up inequities in the healthcare system. There is, as you know, there is a lot of jurisdictional chaos within who gets what service, who is limited to what service. But the truth is, overall, that First Nations and Inuit generally will receive less healthcare services than most other Canadians. And we don't even have a lot of this data. We don't know how many, the proportion of family physicians for First Nations compared to the rest of Canada. My guess would be there's probably 60% less physicians, if not even more than that. Most First Nations and Inuit who live in their traditional communities will have to be traveling out, perhaps even to pharmacies to get some of the drugs. They may have some of the more common drugs be able to provide in community, but some of them may literally have to get on a plane to come to see you. You of course know that there's much less healthcare facilities in a lot of the smaller First Nations and Inuit communities. We still are dealing with a whole bunch of jurisdictional confusion. Are they covered under the Canada Health Care Act? Yes, they are. Are they also covered under the non-insured health care benefits? Well, yes, except of course that pays so much less than everybody else. And I'm going to be just straight up blunt and just to say one of the inequities in the healthcare system, and this has been shown in some evidence, is that there is a level of racism writ large in healthcare. I don't say this pointing fingers. I don't mean this pointing at you. I mean that in the system writ large, there is a built-in bias against First Nations, Inuit, and Métis for all sorts of reasons. But one of them is quite simply that in this country, that we have legislated racism for quite a while, and so it's almost like we're in a bit of a kind of a stasis, trying to learn how to do real inclusion. Kiera, I know that you might have a little bit of some input in here. I'm just going to turn that over to you.
Sure. So in relation to inequities in the healthcare system, I think it's important to mention that us as pharmacists have a responsibility to learn more about what we can provide our clients who are covered under non-insured health benefits. I've I've had in the past working in a pharmacy and prescribing condoms for somebody or Canestin and then being met with, "Are you sure you can do that for them?" And it's all listed in the pharmacist initiated care handouts that they have. In Saskatchewan, there's a nice one through the Pharmacist Association. Um, but you can also find it on the Health Canada website as well. And it's important that we take these opportunities to see how we can provide care for these clients who are covered under NIHB, because in some cases, like Rose had mentioned, maybe they don't want to be going to the doctor's office, or maybe they have a lot of trust issues, or very hesitant to seek medical advice. And maybe they've seen you enough that they have trust in you, that you have these opportunities to maybe provide them with condoms or contraception, just to protect them from like STIs, and just practicing safer sex. Or it's also important that we understand what is covered and what is not. I remember just myself going into a pharmacy for a minor ailment from a pharmacist. And when I asked for it, they looked at me and they said, "And that's covered under your health plan," is what they said to me. And it almost made me feel like I was othered or different, and that it's important that you either look to find the answers to your questions, or ask, because there is customer support and help through NIHB as well, if you maybe need some help to move in the right direction, or to where to find these answers. So I think that's just something important to mention from a pharmacist perspective.
Thanks, Kiera. There is, and thank you for saying that again, is that there really is a lot to learn in all of these sectors, and we're kind of touching on bits and pieces of it, and if in hopes to incent you to continue to do your learning, to serve your clients the best you possibly can. I want to add just a few more pieces around some of the racism that some First Nations, Inuit, and Métis may face. This is a wonderful picture that actually comes out of Lethbridge, and it really does kind of push Canadians and all of us to think about the assumptions that we may or may not have as clients come in the door. It was a wonderful example of and kind of shines a light on some of the stereotypes that perhaps First Nations, Inuit, and Métis may face. There is a couple of stereotypes that are incredibly strong, unfortunately, within healthcare at large. And one of them is that, and I've heard this numerous times, Indigenous people, they are all just, which, by the way, that phrase tends to go badly. They are all just. And I say laughingly, jokingly, but it is true. This the pervasive stereotype within healthcare and in mental health is that Indigenous people, they are all just drunk. I say this from the evidence. I also say this from personal experience. I myself, when I've gone into hospitals, have been asked this as a second question in emergency wards. I could go in training, for example. I train in hospitals, and if I had to go ask for directions at admitting an emergency ward, I would bet that about half the time I'd still get asked, how much have I had to drink today? I certainly have been asked it as I go into, even at times when I have to go in for my own care. It is unfortunately part and parcel of being an ally in healthcare is to be able to name racism and to be able to challenge it when you see it. To challenge it if your staff are kind of buying into some of these assumptions. I was in a pharmacy in North Canada, just a couple months ago, and don't worry, it was not a whole health pharmacy. And I was not dressed professionally. I was in my jeans and favorite t-shirt. And I was in the pharmacy, going to pick up, I don't know, soap or something. And I heard over the announcement system, security aisle 5. Now, I'm a national trainer in anti-racism, so I was laughing to myself, ha, 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 gee, I hope it isn't about me. And then I looked up and I realized I'm in aisle 5. And then I looked up and down the aisle and I realized I'm the only one in aisle 5. And you know what? It just made me feel, again, less than. There was a blatant assumption because of how I look that I was going to be a shoplifter. And that just makes me, it makes me feel terrible that this still is happening to First Nations, Inuit, and Métis in healthcare. I want to talk a little bit more about some of the challenges that you may see in First Nations, Inuit, and Métis clients that you serve, because there is a lot of challenges that we can see in the stats. First Nations, Inuit, and Métis health outcomes overall are not doing nearly as well as other Canadians. And it's not like just a little bit worse. It's more like the difference between Canada versus Sudan worse for healthcare outcomes. So virtually every health stat that we can find in which we can separate out First Nations, Inuit, and Métis health outcomes versus non-Indigenous, First Nations, Inuit, and Métis are doing worse. There's more than 2 to 10 higher incidence in HIV and chronic disease such as diabetes and issues with child welfare. There's much higher incidence of tuberculosis, especially in the north, and much higher incidence and risk of suicide. These are not the blame. These are not the choices that First Nations, Inuit, and Métis have chosen to do. It's not about their lack of coping skills. It actually is simply downstream from colonialization, racism, lack of equity in healthcare service delivery. All of these things are creating factors and risk factors that may be contributing to long-term health inequities that we see right now. I mentioned this, one of them may be mental health challenges. And so I want to just kind of change the conversation a little bit and touch on mental health in the last couple of minutes from an Indigenous perspective and what that may mean for you as a pharmacist. Now one of the ways I want to talk about mental health is actually from a trauma-informed approach. Some of you, I'm sure, have heard about a trauma-informed approach. And really at its center, what a trauma-informed approach changes the paradigm from what's wrong with you to what happened to you. And we think about all the things that have happened over history for First Nations, Inuit, and Métis, from the loss of land to the risk to the Indigenous languages because in residential schools they were not allowed to speak their own languages. to because of residential schools. Again, the loss of family community structure, all of these different pieces we can call losses, we can also call traumas. It's a fairly unique thing that happens in Canada and in the United States, and we call it intergenerational trauma. I want to cover just a little bit about trauma and what that may mean for clients who come in your door. But as I talk about this, I also want to just be very clear that not every Indigenous client who comes in the door is traumatized. That is so not what I want to kind of raise as a flag at all, but I'd like you to be aware that there is a higher risk, that First Nations, Inuit, and Métis clients who come in the door may have a higher risk of concurrent trauma. So really quickly, trauma, very human condition. We all know what it looks like. Probably most of us know what it feels like. The good news is humans are meant to heal. We cut ourselves, we heal. We go through trauma, we talk about it, we heal. So there you go. Trauma-informed approach, 4 years of training and 3 sentences. Here's the thing. Humans actually do pretty well. Most humans do quite well to resolve one trauma. Most humans don't do very well when they go through a number of bad things in a year. And now that's a little bit what intergenerational trauma may look like. So I want to just touch on a few pieces what it may look like for people who come into your pharmacy, what could be impacts of trauma. And again, saying this is, I don't want to stereotype this to say that every First Nations, Inuit, and Métis who comes in the room has trauma. Probably not, but there is certainly a risk. And the problem with intergenerational trauma is it impacts on the whole being, from physical, emotional, mental, and spiritual. People who have gone through too many bad things or have been traumatized over generations may carry a number of barriers to things like there may be barriers for actually immune system. When one goes through a trauma, and we have all sorts of phrases about this, we actually go into what is called a fight or flight. And so if we were in some life-threatening situation, every single one of us as humans go into this fight or flight place, and it's supposed to happen. This is what helps us survive. But when we don't actually find balance and that fight or flight stuff continues, that's what we actually call post-traumatic stress disorder. For people who've been through multiple traumas, multiple loss, potentially those who might be still carrying and enduring intergenerational trauma, there's a whole bunch of things that might occur. Everything from negative impacts on immune system, which then might have a long-term impact on chronic disease. Individuals may carry this high level of stress load. They can't take any more stress. Moving around the clock down into this bottom quadrant around concentration, trauma actually creates a chemical barrier to learning new information. And so this is one piece I really wanted to focus on. You may find people who carry concurrent trauma may not be able to hear you when you talk about the protocols, and may need repetition. And this is not a bad thing. This is a symptom of the disease. It's just simply really hard to take in new information when individuals who are trying to work through trauma are just simply trying to survive. I'm not going to cover much of the other pieces. There is a lot going on the slide. This takes a couple hours to work through. The one other piece I just want to touch on before I'm going to ask Kiera to add in her expertise here too is at some point there may be a good discussion around a trauma-informed approach to substance use. And so just can I just say, without a lot of upfront and lead in, I believe that substance use for the most part is downstream from trauma. Now, I'd hope that we can find a way that we can support people who use substances with the recognition that they're going to most likely need all sorts of supports. For First Nations, Inuit, and Métis who are suffering from concurrent trauma, that may likely mean cultural supports. That is the kind of stuff that probably is not going to be resolved in the healthcare system. That's the kind of stuff that gets resolved out in the land. When people are out in the land fishing, hunting, reconnecting with culture, reconnecting with elders. That is how intergenerational trauma is resolved. Now that's a lot of information. I just did a quick, complete kind of dump on this thing. Usually I take about 2 hours to work through this. Kiera, was there anything else you wanted to add on this piece?
Yeah, so in relation to the trauma-informed approaches to practice, I can't stress how important that is. I know there are courses or online, I guess, information sessions that people can look into. Just just because it's so important that we apply these sorts of approaches to our practice. For example, making sure we change our language, like Rose had said, and making sure we're always asking questions and making sure that they're feeling comfortable with the changes we make or the next steps in a process. And then one thing that stuck out to me the most is always asking for permission when you plan to do something and being transparent about the process. Um, I remember at one of the pharmacies that I worked at, there was an incident with a client, and they were Indigenous. And the reason why that's important comes with the fact that it was a generic medication being changed to a different brand of generic medication, which if you're a pharmacist or you've worked in a pharmacy, it's like a no-brainer. Like, unless it says on their file they stick to this brand, you can change it and you just tell them at the till, kind of thing. Well, in this case, whoever had changed the generic brand to a different generic did not inform this patient, and they called us later and they were extremely upset, and I was the one who answered the phone. And sorry, I always get a little emotional when I tell this story. I've told it a couple times. They were they were extremely upset. They accused the entire pharmacy staff of being racist and that we were just trying to take advantage of them, and that we just wanted to give them whatever we had left, the cheapest of the cheap for them. And I tried my best to explain it over the phone, but he just wasn't having it. And at the end of that conversation, he said he was going to come in later to have it fixed. And I said, okay, we'll see you soon, because I thought this would be a better conversation to have in person. And once I got off the phone with them, one of my pharmacy coworkers asked, "Are you okay?" Which is honestly the worst thing to ask me when um, when something like that has gone on. And to my embarrassment, I bursted into tears and I went to the bathroom because I could hear all of the trauma in what he was saying to me. You could tell that he had a lot of trust issues with the healthcare system, and maybe this hasn't happened before. And I could almost hear my kukum, so my grandmother or my uncle or my auntie, in the things that he was saying, and it really hit me to my core. And I don't think my coworkers really understood where I was coming from in that scenario. And in that case, it almost made me feel alone as well, because I was the only one who had that deeper perspective. So I think that's something that I just want to mention about how important trauma informed approaches can be in helping our clients.
Thank you for sharing that, Kiera. was thinking about something that Senator Murray Sinclair had said, who he was also the Truth and Reconciliation Commission, one of their 3 commissioners. And I keep on thinking what he's also shared. We can look at history as a pain, and it certainly was full of pain for a lot of First Nations, Inuit, and Métis. But we also get to choose to look at our clients who come through the door as having resilience, as having strength. And Kiera, thank you for actually, what a great time to show actually your resilience and strength and your ability to meet your client where he's at. And sometimes there is an impact on you. And sometimes people may lash out, and sometimes that is the trauma. And to not take it personally. And that really is at the core of a trauma-informed approach. You know, the pictures on these next 2 slides, they're actually, they're faces of mental illness. It was a bit of a weird movement and an organization, and I wish they had chosen a different title, but that's what it was. It's every year they used to actually highlight the resilience and strength of individuals who had endured and worked through mental illness to come to a place of balance. And the pictures, there's been a number of pictures in this deck, and they actually have all been of people who've been highlighted for their resilience of working through whatever challenges that they were working through. I also wanted to show these pictures because there's so much diversity within First Nations and Inuit and Métis, and there's really no one stereotype. There's really no average. There is no such thing even as an average First Nation. You will have people coming through your door who are limited to NIHB, and if NIHB doesn't cover it, then they won't be able to pay for it. All the way through to you may have First Nations, Inuit, Métis coming in the door who actually will refuse to use NIHB, and they might say that's a colonial tool and I don't need it. And so I'd ask you to be open around what your client needs and to try and check your assumptions. To finish, I just want to cover just some of the opportunities to continue your learning journey to serve Indigenous clients with the excellence that I know you do. And I guess I'd ask you to think about when you do serve First Nations, Inuit, and Métis clients, to ask them, did they feel culturally safe? Because they are the ones, your clients, who actually evaluate you on your cultural competence. And you might simply ask, how did I do today? Is there anything I can do to improve to give you the best service you need? I'd encourage you to continue to build your cultural competence. There's all sorts of opportunities there's some opportunities to read books, there's courses, not to put too heavy on it, but our company offers a very, very good course on this. I'd ask you to think about challenging your assumptions when your clients come in the door. Did I make an assumption? Should I check my assumption? I'd ask you to really think about to disrupt that deficit assumption, meaning those stereotypes that all Indigenous people are. Usually, unfortunately, in this country, it's a deficit assumption for Indigenous peoples. They're all just. I'd ask you to disrupt that and to look at your clients. Every single one who comes in is bringing strength, is bringing resilience. To set aside some time for your ongoing learning. This is not something that is covered in a couple hours. This cultural competence is actually a lifelong learning journey. We will continue, all of us, to have opportunities to learn from people of different cultures. I'd ask you to consider how you support your staff, that they continue on their journey too of cultural competence. And then I'd also ask you as owners of pharmacies about how your pharmacy contributes to the wider community. This is actually a call from the TRC, calls to action, and you are named in the calls to action as a healthcare provider. And there are calls to action that First Nations, Inuit, and Métis, quite honestly, expect you to uphold. Build relationships with Indigenous communities in your catchment area. Go out to the events, go to powwows, learn, get comfortable being in other cultural events. build relationships with Indigenous leaders in healthcare. For example, the First Nation Health Managers Association. What a great place to learn more about healthcare and what they're doing for First Nations. For Inuit and Métis, there'll be other regional, local, national bodies. But this is a great time to learn. This time we're right now in Canada is a time of reconciliation. We will not have this time for long, and I'm going to ask you to do your part to contribute to reconciliation, both personally and professionally. Kiera, is there anything you wanted to add at this point?
Nope, nothing to add.
Well, I think then we've covered our content. I'm looking forward to see if there are any questions from any questions and comments.
In the comments so much to welcome this knowledge and that more so much. Well, that's to our first question here, and it's for both speakers. How would you suggest that make that connection? Stepping on wrong.
That's a great question. How to build a relationship with the First Nations, Inuit, Métis communities in your catchment area? What's the first step? Kiera, I know you probably have a lot of experience with this supporting pharmacists. Can I just say quickly, in the South, I would suggest to call up if it's a First Nations community, to call up the First Nations Health Manager. First Nations Health Manager, that's the title. Most First Nations will have a role like this. And while that title seems kind of minimal, that role oversees all health and social funding, all health and social services, and in the whole community. That person is crucial for First Nations. If you work in the North, I'd suggest connecting with Inuit ITK, Inuit Tapiriit Kanatami. That's the national organization, to get some input. In the North, I'd also suggest to connect with more of the regional bodies. There's an Inuit regional body in every Inuit land claim organization. I know I'm throwing out a lot of words here. It turns out, as I keep on talking, this is actually more complicated than I thought. I should stop now. There's a whole bunch of ways you could start, but I'd really start with the health manager. Kiera, what would you say?
So I didn't really hear the entire question, but I think it has, I think the question was just looking for ways to connect with the Indigenous communities that they work around, if I'm not mistaken.
Yes, okay. You've got it.
Okay, yeah. So really one thing I would suggest is, like you had said, working with the health manager in the community. Maybe even getting in contact with the health clinic that is on maybe a First Nations community that is near you that you had wanted to connect with, and just finding ways to maybe make yourself more present. I know for myself, I have done a couple medication assessments on the reserve at the community clinics, and I've done some home visits in collaboration with the medical clinics on reserve. So that's something that might be beneficial, or even just working with the maybe the high schools, or the schools on community would be another way to maybe get more involved. Maybe you could have a sort of like information session about maybe what a pharmacist does if you're a pharmacist, or maybe doing some sort of community wellness clinic of some sort might be another way. And yeah, that's what I would suggest.
Thank you. One of the other questions that's come in is, what is the best way a pharmacist should approach a patient who may have concerns or oppositions with regards to Western medicine?
Here I was hoping for simple questions. I think, wow. So Kiera, I'm gonna throw this question over to you, because I would. This is either a thesis or I don't even. Yeah, Kiera, what would you say?
Okay. So again, I was having trouble hearing the question. So it's how do you approach someone who maybe is skeptical of Western medicine? Is that what?
Yes.
Okay.
I think that captures it.
Okay. Yeah. So of course, in my experience, my short-lived experience as a pharmacist, in those cases, what I have done is I'm open to what they have to say and their belief system, because of course we want to be patient-centered when it comes to someone's healthcare. Mainly, I just open it up for discussion. Like if they have questions about maybe a medication they were prescribed, or ask them what makes them so hesitant. Maybe not in that exact question, but just to kind of find maybe the root of why they may feel that way about a certain medication, or this is a hard question. I think to sum it up, it's important to remain patient-centered, and you can talk about how important Western medicine is and the evidence behind it until you're blue in the face, but if someone doesn't want to take it, they're not going to take it.
Good point. Good point. I think there probably is some questions. If a client were to come into your pharmacy, they're looking for information, and they're looking to be heard. The fact that they walked into your pharmacy probably, I would guess, would mean that they're open to it. If they're completely closed to mainstream, to pharmaceutical, I highly doubt they'd come in to your pharmacy, although I could be wrong. I think it's probably about information, and to ask the question, how can I help you? What would be how do you want me to help you? And see where it goes from there.
Okay, those are all the questions we have for now. Before we close, I just wanted to say I